I'm so delighted that the World Heart Federation have included mental health and the interlinking with cardiovascular disease. It's a really critical connection, and I think it's one that remains largely unexplored, both mental ill health as a contributing factor in cardiovascular disease and also mental disorders as a consequence of cardiovascular disease. And so we want to shed some light on the relationship between some common mental health conditions such as depression and anxiety, maybe even PTSD, and look at their overall impact on cardiovascular health. We'll look at some of the scientific mechanisms, how this works, and look at some exciting new evidence which suggests that actually treatment for depression and anxiety might improve cardiovascular outcomes. Also, of course, we always want to think about solutions. We'll be thinking about public health policies and strategies for healthcare providers to effectively screen for cardiovascular risk in people experiencing mental health conditions and vice versa. Now, we have got a fantastic panel for you to discuss these issues. Samuel Sears is a professor of cardiac psychology. He works within the departments of psychology and cardiovascular sciences at East Carolina University in the US. He has a background as a clinical psychologist, but he now trains cardiologists and psychologists on this important science. Also, we have Nadine Kasparian, who is Professor of Pediatrics, and she's the founding director of the Heart and Mind Wellbeing Center at Cincinnati Children's Hospital in the US again. Now, her research, she'll tell you more, but it focuses on understanding how early medical adversity may alter developmental processes, including emotional regulation and stress reactivity. So, welcome to you. And also we have Catherine Karakezi, who is the Chief Executive Officer of the Kenya NCD Alliance. She has a broad experience in NCDs. She's also a member of the board and research committee of the East Africa Non-Communicable Diseases Alliance and a founding director of the Kenyan Diabetes Management and Information Center. So we're going to be hearing three very, very different perspectives. So thanks again. So I want to actually just start with Samuel, if I may call you that, or is it Sam? What do you prefer, Sam? Just so everyone's clear, can you just expand on the intersection between mental health and cardiovascular disease and explain the field, your field of cardiac psychology?
Good. Well, good morning, and thank you for having us here. Cardiac psychology refers to the attitudes and behaviors that both serve as antecedents to heart disease, as well as the attitudes and behaviors that go along with the consequences of heart disease. So it has both a primary prevention role and a secondary prevention role. In short, anything that involves the heart involves the mind.
And so just explain a little bit about what you do, how you work in East Carolina.
Yeah, at East Carolina, we co-train cardiologists and psychologists together. And the cardiologists teach the psychology trainees, and the psychology faculty and the psychology trainees teach the cardiology fellows. This interaction, I think, is a key element to the future in developing service lines, developing providers who have the confidence to manage the mental characteristics that go along with heart disease. So this integrated clinic, same place, same time, same group, same disease. Those are the things that make this kind of a unique training site for us, and why I think it can serve as an important model in many other places.
Yeah, and so what was the reason behind the innovation for this centre? Was there one person who thought this was a good idea and was pushing it, or why isn't it more widespread?
Well, in short, I've been impressed by the innovation in cardiology. The technology in cardiology, the progress in cardiology is impressive. But in my view, we leave benefit on the table. When we fail to engage patients in the experience of living with this disease, in capitalizing on the technologies and innovation, in my view, we leave benefit on the table. It's like some sort of tragedy where we have this incredible technology that could change the world, like an implantable defibrillator that can identify an arrhythmia, confirm an arrhythmia, write it down, provide a therapy, make a decision and provide a therapy. That's human characteristics in which we have devices that do that now. But what good is that device if the patient who receives that device is terrified from the cardiac arrest they've suffered, terrified to return to activity, terrified to be a part of their family and go back to work in the ways that they want to? That's a great technology where we leave the benefit on the table. That doesn't make any sense. So that's why we started.
Okay, and I just want you to expand about that, the patient being terrified. I mean, you've talked about you've been training the professionals, but just tell me a little bit about the patient experience.
Yeah.
And why that is being ignored currently, potentially in many centres.
Medicine's made incredible progress via reductionism. We've made progress in the world of medicine because we've reduced problems down to the smallest elements in order to solve them. But as we've succeeded in managing heart disease in many ways, particularly heart failure and arrhythmias, we have to go back to a kind of holistic picture again, because the reductionism can only get us so far because we can leave out the human elements. And that's been an impressive journey. But it's also fractionating the journey if we don't put the pieces back together and say, wait a second, now we've got this incredible technology, these incredible medicines, we have cardiac rehab that works. How do we get people into cardiac rehab? How do we help them overcome the fear of exerting themselves again, feeling their heart beating faster when in fact there's somebody who has had problems with their heart beating faster. And you say, wait, you want me to make my heart beat faster? Yeah, I do. Because otherwise fear grows where people are afraid to confront the health problem. And whether it's mental health stigma, whether it's the lack of providers, whether it's not the inclusion of psychologic conceptualization in how we manage this disease, we end up leaving out of the picture. And in my view, when we leave psych out of the picture, we leave benefit out of the picture for patients.
Okay. And just briefly, Sam, if you could just elaborate on this mechanism underlying the relationship. How does it actually work?
So the relationship between psychologic factors and heart disease, in particular, what is consistent between both these diseases is a disengagement process, right? People who are sad, people who are anxious, they kind of withdraw. People who are worried about their heart, worried about causing or provoking a heart problem, they withdraw too. So you have this double process of withdrawal that can occur. So in my view, the simplest way to describe it is behavioral. But there are other ways, of course, including the inflammatory processes, things that are hemodynamic in nature that have to do with hyperarousal and have to do with platelet aggregation. And so there are both physiologic and behavioral pathways, and obviously the behavioral pathways are frankly easier to demonstrate. So we think that there's both a behavioral and a physiologic pathway by which psychologic factors impact heart outcomes.
Great, thanks. Sam, we'll come back to you, but I want to move on to Nadine. Nadine, your research, it focuses on the emotional and the neurobiological development of children with congenital heart disease. Can you tell us a little bit more about that and about how that affects them?
Yeah, thanks, Jackie. I think to take a step back, we know that congenital heart disease is the most common birth defect, affecting around 1 in 100 live births. We know that 25% of babies with congenital heart disease will require life-saving surgery in the first year of life. But what we often don't talk about is the fact that 1 in 3 children with congenital heart disease will experience a mental health condition, whether it's neurodevelopmental or psychiatric. And the lifetime prevalence of anxiety and depression in adults with congenital heart disease is 50%. That's 1 in 2, which is a strikingly high rate, much higher than in the general population. And so in our field, in congenital heart disease, we're working very hard to better understand the factors that contribute to these adverse mental health outcomes. We're looking at genetics, at cardiovascular function, we're looking at stress, we're looking at early adversity, we're looking at neuroprotective mechanisms to better understand that interconnection between heart and mind.
You say that 1 in 2 of the children who grow into adults have some kind of issue. What is the most common disorder?
Yeah, the most common. We recently published in Circulation a population-based nationwide longitudinal study looking at the prevalence of a whole range of different neurodevelopmental and mental health conditions. We found 35% of children had some form of mental health condition by age 18. The most common were developmental disorders, anxiety and ADHD. And one thing that was striking in our findings is when incidents occurred. So we found, for example, peaks in incidents in acute stress and severe stress in early childhood as well as in adolescence, really giving us an understanding of how early we need to be intervening and providing buffering and supportive interventions for children and their families.
I think that, you started on this journey some years ago. I got the figure 2007 in my head. I can't remember what that relates to now, but maybe you could explain. I mean, what was it about your work that you decided to, concentrate on this area?
Yeah, thank you. So I had the good fortune of starting one of the first psychology programs dedicated to childhood heart disease, which is shocking, really, that in 2007 it was one of the first. And I think it's because in our field we've been hyper-focused on survival, as we should. We've seen tremendous triumphs in medical and surgical advances in the past 4 decades, but we've really lagged behind in terms of that coupling of mental health support. And so our program is dedicated to working before children are even born. So we start at the time of prenatal cardiac diagnosis, working with parents who receive their baby's diagnosis during pregnancy, and work throughout the lifespan, really, both in hospital and beyond hospital walls, with infants, children, adolescents and adults. Our most senior patient at the moment is 72 years young and had her open heart operation when she was 6 and came to us for treatment of post-traumatic stress to be able to have a cardiac procedure that she really wasn't able to have given the level of traumatic stress that she was experiencing.
Wow, that's really fascinating. Okay. And so maybe you could talk about some of the other interactions that you've introduced to help these children and adults, and I didn't realise that you saw patients all the way through like that. And what works, and what about the parents as well as the children? Because I think that support's needed for them too, right?
Yeah, I think that continuity of care is something that we don't see in many places, and we know, and our patients tell us, is absolutely vital. Working with mental health professionals that deeply understand cardiac disease is incredibly important and therapeutic. I think one of the biggest innovations we have is starting during pregnancy. We know that parental stress has important implications for the developing brain, the developing mind of a child. And so being able to work with parents, we know that 1 in 2 parents experience clinically high levels of anxiety after receiving a prenatal diagnosis of congenital heart disease. We know that 4 in 5 parents at some point experience traumatic stress in their child's medical care. And so without protecting and without working with and therapeutically engaging with parents and families, we are not doing the best we can. We know that parent mental health is the single strongest predictor of child mental health, and yet often many programs aren't able to provide that family-centred care that we know is so important.
I'm going to come to Catherine in a minute, but before I do, I just wanted to ask you two. I'm struck and taken by the fact that we've got 2 US experts on this. Is this something that the US is very strong and has pioneered, and is it in Europe, is it less visible, or... Sorry to throw that one at you.
Yeah, I'm not sure if it's so much that it's slow to accept. I think we've just had an opportunity to innovate there, perhaps. I mean, at times we perhaps have more resources to move in these directions, but I don't know. Part of it's a little bit of headstrongness of Dr. Kasparian and I saying we're going forward here. I don't know.
Yeah, I think especially in our field, we cannot make progress unless we're working together. And more there are international collaboratives, international collaborations, and that is the way to move the needle forward. So we are seeing growth across the globe, which is really important.
Brilliant. Okay. Well, maybe we're going to have time for questions in a minute. So maybe if anyone has got any thoughts on that or questions relating to the European US, that can bring it up then. But let me come to Catherine. Catherine, we've heard from these two US speakers. I wondered what resonated. It must be a very different experience in low middle income countries where access to mental health services, full stop, are challenging in many areas. Well, first of all, what do you take from what you've heard from these two?
Well, firstly, thank you very much for the invitation to speak on this panel. Yes, it's very different in the sense that access to mental health in our countries is very limited. For example, I'm from Kenya. We have one mental referral hospital, which was set up many years ago. Very few psychiatrists. Yes, psychologists are available. But generally, when it comes to non-communicable diseases, the main emphasis is on managing the condition. And even for a diagnosis, after the diagnosis, there's very little counseling in terms of how you're supposed to live with this life-changing condition, which you'll live with for the rest of your life. So I guess in a sense, one is supposed to accept the diagnosis, focus on controlling the condition, and life moves on. But having worked with persons living with NCDs, one of the first things I did was interview persons living with NCDs in terms of how was the diagnosis delivered, what kind of care did you get after the diagnosis. But essentially one is just supposed to pick up their life and move on. And yes, I do recognize that we do have limitations in terms of the health systems, in terms of the healthcare providers available, the psychologists, psychiatrists, and so on. But essentially, just receiving a life-changing diagnosis should actually have some counseling available. And we have recognized this. I do work with children living with type 1 diabetes with the Kenya Diabetes Management and Information Center. And we realized, yes, providing insulin, yes, is important. But you cannot have optimal control if the mental status and the psychological status of the individual is not optimum. So really, we then started having counselors on board, just working with the children to find out where are you at with your diagnosis. We then realized that the parents were being left behind, which is often the case. We focus on the patient and forget about the caregivers. So we then started talking to the parents and realized that many parents did not know that there are many other parents with children living with these conditions. So bringing the parents together and just having discussion forums, more like a support groups for people to share their experiences, to meet other parents, to understand the challenges that parents face, and to also understand that you're not alone. And there is a community that you can actually share with. This has actually helped in terms of optimizing the treatment and care for children, and also bringing the children together in camps and things like that has also enabled them to understand they're not alone. There are many other children living with type 1 diabetes or living with rheumatic heart disease or sickle cell disease, and just understand that you're not alone. There are people who can help. These camps enable the children to interact informally with the healthcare providers, to learn more about their condition, and also to be counseled about how better to cope.
But let me take a step back. You say that obviously, largely, people are given a life-changing diagnosis and then told to get on with it. What's the impact on their subsequent health for that type of scenario?
Well, obviously, yeah, it's suboptimal management. You really don't know how to cope in most cases. You're expected, if you're an adult, to go back to work, and you're dealing with all these other challenges. Maybe you need to go for regular checkups and everything. Your employer may not understand. So I do know that some people have lost jobs as a result of not being either able to cope with a condition and also absenteeism to go for further medical checks and so on. So I think it's a case of learning to treat the individual, not so much the condition. And also recognizing, yes, we do need to treat the condition, but treat the condition in the individual, but don't divorce the two. And just recognize the impact of these conditions on your life moving forward.
And so you've talked about the impact you've had with children with diabetes and other conditions. How have you been able to integrate mental health support initiatives for adults?
Again, through the hospital clinic setups, what we've done is started counseling sessions, working with the nurses Also, in some of the hospitals, we do have psychologists. So bringing the nurses and the psychologists together and just starting these informal discussion groups, trying to identify individuals who are not coping, either, for example, poor blood sugar control, or just absenteeism from school or from work. Just trying to work with a specific individual and see what challenges are you facing? Why is it you're not able to cope? And then again, just seeing how best to bring on the counseling sessions. And also now we've started, obviously, having separate clinic days where you can have more focused time with people living with different conditions. And this has enabled us to have more time with the individuals and also to have more focused counseling in terms of self-management and issues like that. So that is something that we've started doing. And then also in some of the programs we're running, just bringing on board the mental health component in terms of if you're training healthcare providers, just have a counselor or a psychologist as part of the training team, the facilitation team, for them to come and talk about what is the impact of these conditions on an individual. How can you help a person? And how can you identify somebody who's really struggling, and what should you do in that situation? So just basically bringing mental health into the general management of diabetes or hypertension and other conditions for the healthcare providers to understand, yes, there is a mental health component.
Yeah.
We need to deal with this.
Sam, I want to come in, I think, please.
Yeah, I'm reassured by her comments in that even in diabetes as a sort of entree into cardiac care, even there the human aspect of living with this disease comes out. I mean, there's some data that's maybe a little bit maybe inflammatory, but it's like 143 minutes a day to manage diabetes. I mean, that's like a full-time job. I know that study sort of magnified some things, but the idea here is that when we talk about self-care of chronic disease, it is a big job, and it does interrupt with life. And so I think that as we've moved away from hospitalizing everybody for long periods of time, we've pushed care back into self-care. And you mentioned self-management, but I was reassured in that your experience has also suggested that basically routinely addressing the impact of the disease on people made sense. And we have some data that suggests as we do that, we really do improve both the disease outcomes as well as the, if you will, psychosocial outcomes.
I want to come on in a minute to stigma, but I just want to talk about some of the challenges that you've had in introducing the systems that you've talked about. I'm keen to hear from Sam as to how the cardiologists took it on board. How did they like being trained by psychologists? How does that work? And also you're doing the same thing, Catherine, in diabetes. Sam, do you want to kick off?
Well, we've done that a couple of different ways. First off, I think psychology's got to sound and speak like cardiologists a little bit, and cardiologists begin to sound and speak like psychologists a little bit. In addition, Dr. Kasparian and I both publish a lot of papers in cardiology, so we target our research into their journals, which kind of makes it hard for them to dismiss it, right? Because if you published in their base journal, hey, you don't read your own journals, you know, you kind of scratch your head. And so that's one of our secret ploys. She mentioned publishing in Circulation. Well, that's a key cardiology journal. And so ways in which we begin to communicate with the same venues, participate in meetings like this, and vice versa. So it begins this whole familiarity process. And for us, finally, clinically, it's to be in the same place, same time, same locale.
Dr. Kasparian, you want to come in?
Yeah, I mean, when I started in this field and first met cardiologists at the Heart Centre in Sydney, the first question so many cardiologists and cardiac surgeons asked me was, who are you here for? Are you here for the patients and families, or are you here for us? And it just spoke volumes about the level of psychological stress and burnout and mental health fatigue that our cardiac teams experience. And in our roles, we're really there for everyone. We're there to be part of the team, and we're there for the team, and we're most certainly there for patients and families. So, I think there are ripple effects when you have mental health professionals and mental health care infused in a cardiac service, and everyone plays a role in that in some way.
Thank you. Catherine, did you want to add how did the health professionals take on board this counselling, introduction, etc., and this emphasis on mental health as well? Were they positive about it?
Yeah, they were positive about it. And I think it's also something they had kind of recognized, but they were not able to deal with. So they really appreciated the fact that they were being taken through this kind of introduction and just knowing how to help the patients that they're working with. Yeah.
Okay, thank you. I want to come to stigma. We know that many people find it hard to access or accept themselves they need help. Have you found that? How do you get over that? Or is it easier because people are aware they have a condition, a physical condition, which could be benefited? Sam?
Well, the first thing, I think we've got to make mental health kind of cool. Right? Hey, who don't want to get stronger? Who don't want to be more resilient? Anybody in here want to be weaker these days? Nobody, right? So the idea here is that, hey, psychological processes make us better. They put our best self forward every day. So from my standpoint, I think we start with the idea of, what are you talking about stigma? Everybody wants to be the best version of themselves. Secondly, we talked, and Dr. Kasparian mentioned the rates of distress in our patient populations, and she reported some staggering rates there with parents and kids. Well, the same thing's true in advanced heart failure and arrhythmic care and electrophysiology. We see about a third of our patients having a diagnosable anxiety or depressive disorder, but 100% are affected. Everybody's affected. Now, they might not have a diagnosis, but nobody has significant heart concerns and then goes, yeah, this is a walk in the park. So we defeat stigma by both changing the way we talk about it, bringing it to be a natural kind of conversation, which is kind of what your group's doing, making it a natural, of course you have type 1 diabetes, of course there's some distress associated with it. And then secondly, recognizing that it's a universal experience to have concerns about what you've been diagnosed with. So we reduce stigma by both of those means, in my view.
And Nadine, it was children. Are they more open to seeking help, or is it the young generation, or what do you find?
Depends how old they are. I think we have to be able to, hand on heart, say we offer this to everyone to destigmatize. I think that integration, goes a long way to being able to do that. Often for us, it's the first time that a patient or family has met a mental health professional. And to see us be part of the cardiac team, a routine, expected part of their care, is incredibly important. Having conversations about how you're doing part of the cardiac consultation it helps and goes a long way. But most importantly, I think the interventions and the treatments and the programs that we developed are developed in partnership with patients and families. And without that piece, we just cannot hit the mark in terms of what we need to do.
Okay. After we speak from Catherine, we're going to come to questions from you guys. So yeah, please, I'm pleased to see that instantly everyone are getting up. Fantastic. But Catherine, that stigma angle that I just talked about, particularly inherent, I'm presuming in countries like Kenya, how do you deal with the stigma?
Just to mention, in terms of stigma, both for diabetes and other NCDs, as well as mental health, it's a big issue. Generally, in many of our societies, if you can't explain something, then it's either witchcraft or a curse, and therefore you'll tend to be kind of ostracized. So many people will not come up and actually say that they're living with diabetes or living with a heart condition, and that really is a challenge. But then also you'll find that it might be more acceptable to have diabetes than to have a mental health condition. So there is a lot of stigma associated with living with either mental health condition or diabetes, cardiovascular disease. And this has really inhibited the awareness in the community in terms of, for example, we don't have any positive role models of persons living with diabetes. And yet when I think of a lot of our senior politicians and so on, I mean, a good number of them, I believe, are living with diabetes or hypertension or something like that. But nobody will come out and say that I am living with diabetes. Because previously, many people are being diagnosed with diabetes when they already had complications. And so diabetes was seen as a death sentence. And then, of course, mental health is perceived as a curse. So there is that stigma in the society, and it's a big challenge for people to actually admit that they're living with these conditions.
Thank you, Catherine. Okay, I'm pleased to come on to our audience.
There we go.
Yeah, that's brilliant. Please.
Hi, I'm Amy Verstappen. I'm the president of the Global Alliance for Rheumatic and Congenital Hearts, which is, we have over 70 patient and family group organizational members, most of them in low and middle income countries. I did want to answer the question that was asked about Europe more extensively, which is Europe actually is well ahead of the US, so I don't want anybody to think they're not. They were pioneers in the field. I also want to note that one of the surprises, so I ran the Adult Congenital Heart Association for over 13 years. I've been doing this for 27 years. And what is so striking is anytime you have a conference or you bring patients together, the first thing they will ask is they will say to the clinicians, okay, you put all this effort into keeping me alive. Why aren't you talking about this? Dr. Kasparian mentioned that that is the #1 morbidity in congenital heart disease, #1, okay? And what I would note, and I actually have three things, sorry. What I would note is, first of all, there is a striking research gap. So one of the things our organization does is recognizes gaps between patient-centered research and what is being researched. It's huge in this area, and this is global. So we do a huge amount of clinical research on other things, but we know this is a problem, and yet I recently looked it up. There are under, I think, 5 studies that have been done actually on what's effective. The second thing I want to say is that actually there's another big barrier to this that nobody mentioned. So essentially, one of the ways Europe is ahead is they do include mental health for congenital heart patients in universal health coverage. This is mandated in most healthcare systems. However, the way they do it is very limited, and the reason it's limited is money. So for example, one of the things we found out from one of our groups is that they only do it where you get your care. So when you go home, you don't get it. And the third thing I'm going to add, and I know you're gesturing to stop me, but there's an aspect of stigma that also has not been raised. I didn't understand stigma until I understood low and middle income countries. Literally, so I'll give you a very concrete example. We have an organization called the Pakistani Children's Heart Foundation, started by a father, and they bring children in from rural areas, they pay for surgery, and they will pay for them to come back. None of the families are coming back. It doesn't matter how much money they offer, because if somebody in their village knows that that child has congenital heart disease, not only will they never get married and never get a job, but their siblings will not either. Because that's the culture.
Okay.
So anyway, thank you.
Thanks very much. Okay, let's go on to a question. Yes, please.
Thank you. Amam Bakwem from Nigeria. I would like to touch on the stigmatization that we raised, but I think we should, talk to the population, because in my country, if you talk about mental illness, it means you've gone cuckoo. Doesn't matter what it is, whether it's anxiety, whether it's depression, you are seen as mad. We did a study in our center, on heart failure patients, and about 25% of them had moderate to severe depression, and we referred them to the psychiatrists, and they never went. So what we did was turn the thing around, then get the psychiatrists to sit in our clinics, so that if you felt somebody wasn't really coping well or had issues, you would ask them, see the doctor in the next room. They didn't know who they were seeing, because if they knew they were psychiatrists, they wouldn't talk to them.
Yes, that's a really, really good point. Yeah,
there is some data for that. That's exactly why we are integrated in cardiology. There is some data where they referred people with heart problems to an off-site psychiatrist, psychologist, and it was a zero follow-up, whereas it's like 75+% when you're in-house. And it makes a lot of sense. It's a one-stop shop, but it's also what you talked about in terms of overcoming stigma and seeing it as, this is your heart team. Of course we're going to address that.
Yeah.
Yeah, and I think we exist in a very medical and medicalised model. The reality is that it's normal as a child to be sad that you're not playing with your friends because you're in hospital. It's normal to be angry that you're in hospital over the holidays. It's normal to be frightened of your upcoming surgery. And the more and more we're able to normalise these very understandable responses to abnormal situations, the more that we can melt that stigma.
Thank you. Okay, gentlemen, let's have the gentleman at the back because you've been waiting a long time, and then we'll have the gentleman at the front.
Thank you. I'm Trevor Shilton. I'm on the board of the World Heart Federation and chair the WHF Advocacy Committee. And I work in physical activity both from a scientific, behavioural and policy perspective. So Sam, you mentioned primary and secondary prevention, and I just want to take us into the primary prevention space for a second, and I welcome your comments. People who are physically active are less likely to have depression, they're less likely to have anxiety, they're more likely to have quality social support, and they're less likely to be lonely. So how can we bring these two very important risk factors of poor mental health and physical activity together and realise the population-wide synergies?
Good question,
So,
Sam.
yeah, so from a primary prevention standpoint, you're exactly right. And I think the most recent trials within the last 6 months even have highlighted that there probably is an antidepressive, anti-anxiety effect from regular exercise in normal populations, healthy, non-cardiovascular disease populations. So we're learning that. I think we're seeing that. We're going to see more and more clinical trials, even in the heart failure and arrhythmia space, that are going to involve exercise as a way to both strengthen cardiovascular health, but also strengthen mental health. So you're absolutely on the right track. Now, you asked how could we do more with that? I think the introduction of accelerometry, the introduction of step counters and things like that starts to put numbers on people's activity, not just Surgeon General recommendations or World Health recommendations, but truly like, okay, how do I reach what you're asking me to do? Rather than just time, actually steps and things that can be just much more operationalized.
Thank you. Okay. Last question from the gentleman here. Yeah.
Thanks. It won't take long because Trevor's stolen my thunder. I wanted to get onto primary prevention too. Look, I'm David Lloyd. I'm CEO of the National Heart Foundation in Australia. There is a wonderful charity in Australia called Beyond Blue. And the CEO of that and I have this running joke that she can't get anyone over 40 to listen to her and I can't get anyone under 40 to listen to me. And we've identified that as an opportunity. And we do think that there is perhaps somewhere a primary or indeed primordial prevention program where you can, to your point, Sam, about mental health being cool, there is a possibility of us running something in primordial prevention which will really be a very effective cardiovascular and mental health program. My question is, have you seen anything like that in any other part of the world which we could emulate? Because it must have been thought of before.
Well, that's a good question.
Well, I want the Australian native to address this. But what we do have is some clinical trial data in very small populations, nothing at the level that you're talking about. I mean, the Cardiocenti cities that we learned about yesterday was quite impressive. That I had not known about that previously. But just in terms of clinical trials, there have been some clinical trials. They've generally been very well received and the outcomes have been strong. But I think there's still room for innovation in this area, particularly at the population level, because clinical trials are going to be just that. They're going to be selected, highly selected populations.
Yeah, agree. It's very exciting to hear that those two organisations are talking. That's really exciting. I mean, you know, I spend a lot of my time working with parents in pregnancy. I think that we are running a randomised controlled trial at the moment to look at psychological intervention during pregnancy after cardiac diagnosis and the impact not only for parents and families but also brain development and neurodevelopment and later mental health outcomes for children. And then what we do by the bedside is absolutely critical. Inpatient, individualised developmental care by the bedside in our cardiac intensive care units, in our step-down units, is something that we're seeing more and more of, and we need those robust trials. We need the funding for those robust trials to be able to see the benefit of those. But yeah, thanks for letting us know. That's really exciting.
Great. Well, it's been such a wide-ranging discussion and some great contributions there from the audience. But I do want to end the session now and just ask each of my panelists just a very quick 30 seconds. What's the one thing you want the audience to take away about this intersection and interconnection between mental health and cardiovascular disease? Sam, I'll come to you first.
I think the idea that psychological health is part of a comprehensive success plan, that we want our patients to encounter heart disease, be treated for heart disease, and move on from there to actually return and resume life. We also want to prevent it, but my work's very much focused on secondary prevention. I think the idea is, don't we want that? Don't we want those kinds of comprehensive outcomes? I think the fact that we're here today is just great evidence that the World Heart Federation and that this is an issue for our time. And it represents the next step, in my view, of achieving comprehensive health.
Thank you, Sam. Catherine.
Just to say that there is life after diagnosis. So let us look at the whole person, not just the condition.
Thank you. And a final word from you, Nadine.
I would say that some of our research has shown that depression amongst people with congenital heart disease is associated with biomarkers of inflammation, biomarkers of heart failure, and a 3-fold increase in mortality. Side by side, research this year has shown that when patients with heart disease have access to mental health treatment, we see a 75% decrease in readmissions, 75% less likely to present to ED, and a 65% less likely to die of all causes. We have all the research we need. We need to be implementing. The time is now, and the challenge is for us to integrate mental health into cardiac care.
Brilliant. Well, thank you very much indeed. A great panel, great discussion, and yeah, thank you.